Right now, as you're lying there in the dark, ask yourself a strange little question. Why can something go wrong in your lower back? A joint, a disc, a small structure not much bigger than a coin, and end up producing pain, numbness, or a strange electrical tingling all the way down in your foot, sometimes in a toe a full body's length away from where the actual problem sits? The obvious answer, something about a trapped nerve, is only the surface. The real answer involves the longest, thickest nerve in your entire body, and it cuts across 2,500 years of wrong guesses. A hip disease that turned out not to be a hip disease at all, and a mystery that took until the 1930s to genuinely solve. And if you're here because that exact sensation has been bothering you, running down the back or side of your leg, sometimes as far as your ankle or your toes, you're in the right place. Not because we're going to give you a list of fixes, but because once you actually understand what sciatica actually is, and more importantly, what it usually isn't, most of the fear that comes attached to it tends to dissolve. And sometimes that understanding is the thing that needed to happen first. It's worth pausing on that word usually for a moment because it's doing quite a lot of work in that sentence. And it's worth knowing exactly why before we go any further tonight. The fear attached to sciatica very often comes from a handful of specific assumptions. That it always means a disc has slipped, that it always requires surgery, that the sensation traveling down the leg reflects some kind of ongoing, worsening damage to the nerve itself. Each of those assumptions we're going to walk through carefully tonight turns out to be considerably less certain than it sounds. But let's start somewhere closer. Right here, in your body, in this moment. So let's look at what's actually happening when sciatica shows up. Right now, even lying still, the nerve at the center of all of this, the sciatic nerve, is quietly doing its ordinary work, carrying signals between your spinal cord and your leg, whether or not it's currently causing you any trouble at all. Here's the first thing worth knowing, because it reframes almost everything else tonight. Sciatica is not, technically, a diagnosis. It's a description of a symptom, pain that travels along the path of the sciatic nerve, and that symptom can be produced by several genuinely different underlying problems, which matters enormously for how it's actually treated. The sciatic nerve itself is formed from several nerve roots, typically labeled L4 through S3, emerging from between the bones of your lower spine, which then merge together into a single thick cord, roughly the width of your thumb, running down through the buttock, along the back of the thigh, and splitting further below the knee to eventually reach the foot. It is, by a comfortable margin, the longest and thickest nerve in the human body. And it's the reason a problem sitting entirely within your lower back can produce sensations somewhere as distant as your little toe. The most common trigger for genuine sciatica is irritation of one of those nerve roots, right where it exits the spine, usually from one of two sources. The first is a disc problem. Between each pair of vertebrae sits an intervertebral disc, a flattened, roughly circular cushion with a tough, fibrous outer ring called the annulus fibrosus, and a softer, gel-like center called the nucleus pulposus. Here's a myth worth correcting immediately, because the language around it is almost universally wrong. Discs don't slip. That entire phrase, despite how deeply embedded it is in everyday conversation, describes something that doesn't actually happen. Discs are firmly anchored to the vertebrae above and below them. What actually happens when a disc causes trouble is that a small tear develops in that tough outer ring, and some of the softer gel-like center pushes through it. A herniation, or a prolapse, not a slip. If that herniated material pushes against or chemically irritates a nearby nerve root, that root can become inflamed and sensitive, sending signals down the entire length of the nerve it belongs to, which is why the sensation shows up in the leg or foot rather than simply in the back where the actual disc problem sits. Like the cartilage we've discussed in other contexts on this channel, the intervertebral disc has no direct blood supply of its own. Once past early childhood, it's one of the largest vascular structures in the entire human body. It's nourished instead through diffusion, nutrients and waste products moving slowly in and out through the porous bone surfaces above and below it, and through its own outer fibrous layers, a process that works considerably better with regular, gentle movement than with prolonged stillness, since movement helps drive that diffusion along through small pressure changes within the disc itself. This is part of why extended immobility tends to be poor for a disc's long-term health, and it's a detail worth holding on to for later tonight, because it connects directly to some of the more persistent advice around managing sciatica. It's worth understanding, briefly, how the disc itself changes over an ordinary lifetime, because it explains why herniation becomes more common with age, even without any specific injury. In youth, the nucleus pulposus at the center of the disc is highly hydrated, largely water-bound to specific proteins that give it its cushioning gel-like quality. Beginning surprisingly early, measurable changes can start as early as someone's 20s. The disc gradually loses some of this water content and hydration capacity, becoming somewhat firmer and less able to distribute load as evenly as it once did, alongside small changes in the fibrous outer ring that can make it marginally more prone to developing the kind of tear that allows herniation to occur. This is a normal part of aging, not a disease process in itself, in much the same way skin gradually loses elasticity. But it's part of why disc-related sciatica becomes considerably more common through midlife than in early adulthood, and part of why the facet joints at the back of the spine, small joints that also bear load and can develop their own arthritic changes, increasingly share responsibility for symptoms alongside the disc as people age. The second common source is spinal stenosis, a narrowing of the space available for the nerve roots to pass through, generally developing gradually with age as the joints, ligaments, and discs of the spine thicken or change shape. Stenosis tends to produce a somewhat different pattern than a fresh disc herniation, often worse with standing or walking, and noticeably eased by bending forward or sitting, because that position tends to open up the narrowed space slightly, giving the nerve root a little more room. There's a third, more debated source worth mentioning: the piriformis muscle, a small muscle deep in the buttock through which the sciatic nerve sometimes passes very closely, or in some people's anatomy, directly through. If this muscle becomes tight, inflamed, or spasms, it can, in some cases, compress the nerve at that specific point rather than at the spine at all, a condition sometimes called piriformis syndrome, though how commonly this actually explains genuine sciatic symptoms remains a subject of real disagreement among researchers, in part because there's no single, universally agreed diagnostic test that reliably confirms it. More recent research has actually broadened this category somewhat, recognizing that several other small muscles and structures in that same deep buttock region, not just the piriformis specifically, can occasionally contribute to nerve compression. At that level, a broader diagnostic category, some clinicians now refer to as deep gluteal syndrome, acknowledging that the single muscle framing may itself have been a slight oversimplification of a somewhat more complex, multi-structure region. Whatever the underlying source, it's worth understanding what actually produces the specific sensations people describe. The pain, but also the numbness, the tingling, the occasional weakness. Nerves carry different types of fibers bundled together, some carrying pain and temperature information, some carrying the fine touch and position sense that lets you know where your foot is without looking at it, and some carrying the motor signals that tell muscles to contract. Depending on which of these fibers are most affected and how severely, the experience can range from a sharp, electric, shooting pain to a duller ache, to numbness or pins and needles, to, in some cases, a genuine weakness in the foot or ankle, all from what might be, at its source, a fairly modest amount of irritation to a single nerve root. Whatever the underlying source, it's worth understanding what actually produces the specific sensations people describe, the pain, but also the numbness, the tingling, the occasional weakness. Nerves carry different types of fibers bundled together, some carrying pain and temperature information, some carrying the fine touch and position sense that lets you know where your foot is without looking at it, and some carrying the motor signals that tell muscles to contract. Depending on which of these fibers are most affected and how severely, the experience can range from a sharp, electric, shooting pain to a duller ache to numbness or pins and needles, to, in some cases, a genuine weakness in the foot or ankle, all from what might be at its source, a fairly modest amount of irritation to a single nerve root. There's a more precise clinical term worth knowing here because it separates true sciatica from other kinds of leg pain that can superficially resemble it. Radiculopathy, meaning irritation or dysfunction, specifically at a nerve root, as opposed to pain that simply refers into the leg from muscles, joints, or other soft tissue in the lower back without any actual nerve root involvement at all. This distinction between true nerve root pain and other kinds of referred pain from the lower back is worth spelling out a little further because it's a genuinely common source of confusion. Structures like the small facet joints at the back of the spine or tight irritated muscles in the lower back and buttock can also produce pain that spreads into the buttock and upper thigh, sometimes called somatic referred pain, arising from ordinary sensory nerve pathways shared between these structures and the surrounding region, rather than from irritation of the sciatic nerve itself. The practical clue clinicians use to distinguish the two, somatic referred pain from the facet joints or muscles, alone tends to stay relatively localized to the buttock and upper thigh, rarely traveling clearly below the knee, and tends not to follow the precise dermatome mapping we described a moment ago. True radicular sciatica, by contrast, much more reliably travels the nerve's actual path, often reaching the calf, the foot, or specific toes, and follows that specific dermatome pattern with far more precision. Not every ache in the buttock or thigh is sciatica in the strict sense, even though it can feel similar in the moment. A distinction worth knowing simply because the two have somewhat different typical causes and, at times, different management approaches. This distinction matters clinically because true radiculopathy tends to follow a remarkably specific, almost map-like pattern, since each nerve root supplies a particular strip of skin, called a dermatome, and a particular group of muscles, called a myotomy. Irritation at the L4 nerve root, for instance, tends to produce symptoms along the inner shin and can weaken the muscle that lifts the foot upward. The L5 root maps to the top of the foot and the big toe, and its weakness can show up as difficulty lifting the big toe or, in more significant cases, a genuine foot drop, a noticeable slap of the foot while walking from reduced ability to lift it clear of the ground. The S1 root maps to the outer edge of the foot and the sole, and its involvement can weaken the calf muscles. sometimes affecting the ability to rise up onto the toes. This mapping is precise enough that an experienced clinician, simply by asking careful questions about exactly where the pain, numbness, or weakness shows up, can often make a strong educated guess about which specific nerve root is involved well before any scan is taken. A genuinely elegant piece of diagnostic reasoning built entirely on understanding the nerve's actual architecture. There's a diagnostic tool worth mentioning too, because it approaches the nerve from a different angle than imaging entirely. Nerve conduction studies and electromyography, sometimes shortened to EMG, which measure the electrical signals a nerve and its associated muscles actually produce, rather than photographing the structure around them. Where an MRI shows what a nerve root looks like, an EMG shows, in effect, how well it's currently functioning electrically, useful specifically in cases where the clinical picture is ambiguous, or where imaging findings don't clearly explain the specific pattern of symptoms someone is experiencing. It's a reminder that understanding a nerve fully sometimes requires looking at it through more than one kind of technology, structural and functional together, since neither on its own tells the whole story. This is also a good moment to return to something we've touched on in other conversations about pain in the body. The mechanism generating the sensation is never purely mechanical. Nerve root inflammation involves the release of specific inflammatory chemicals, including one called substance P, that sensitize the nerve fibers themselves, making them fire more readily and more intensely than they otherwise would. This matters because it means the size of a disc herniation, visible on a scan, doesn't map cleanly onto the intensity of pain a person actually experiences. A relatively small herniation producing a large chemical inflammatory response can hurt considerably more than a larger herniation that isn't chemically irritating the surrounding tissue as much. We'll come back to exactly how surprising this disconnect can be, because the imaging research on this is genuinely striking. So here is a more accurate picture to carry forward. Sciatica is not one single disease with one single cause, and it's not the result of a disc quietly slipping out of place. It's a description of nerve root irritation arising from a handful of possible sources, driven as much by chemical inflammation as by pure mechanical pressure, traveling the enormous length of the longest nerve in your body before it ever reaches conscious awareness in your leg or foot. It's worth sitting for just a moment with how genuinely remarkable that nerve's engineering actually is, independent of anything going wrong with it. A single continuous structure, roughly as thick as your thumb where it leaves the pelvis, carrying millions of individual nerve fibers bundled together, running the entire length of your thigh before dividing into smaller branches below the knee, each one destined for a specific muscle or patch of skin, coordinated with a precision that lets you feel the exact texture of a floor beneath your foot, while simultaneously commanding the muscles needed to keep you balanced on it, all without a moment of conscious calculation on your part. If that's the accurate picture, why does almost nobody talk about it this way? Why do we still hear slipped disc, still hear sciatica described as though it were, historically, a disease of the hip? That's worth understanding too, and it takes us somewhere genuinely surprising. Why do we still hear sciatica described the way we do? A slipped disc, a trapped nerve, sometimes even, historically, a disease of the hip itself? Where did that language come from? And why has it taken so long to correct? The word itself is a good place to start. Sciatica comes from the Greek word for the hip joint, ischion, and the condition was, for well over 2,000 years, genuinely believed to be a disease originating in the hip itself, not the spine. Hippocrates, writing around 400 BCE, described the pattern of pain running down the leg and attributed it to disturbances around the hip joint. A reasonable conclusion, given that the pain so often concentrated in the buttock and thigh, and given that nobody at the time had any way to trace the nerve's actual path back to the spine. That belief, sciatica as a hip disease, persisted, essentially unchallenged, for the entire span of ancient, medieval, and early modern medicine. Physicians across those 2,000 years treated it accordingly with remedies aimed squarely at the hip: heat, poultices, and, for many centuries, aggressive bloodletting and cupping applied directly to the buttock on the theory that whatever fluid or humor had settled there needed to be drawn out. Some historical accounts describe treatments involving the application of caustic substances or even small controlled burns directly to the skin over the hip and buttock, intended to draw out the offending humor through the resulting blister, a genuinely painful intervention, applied in good faith by physicians working entirely within the anatomical understanding available to them at the time. It took until 1764 for the record to be seriously corrected by an Italian anatomist named Domenico Cotugno, working in Naples. It's worth knowing that even Galen, whose flawed animal-derived anatomy we've discussed shaping so much of the rest of this channel's history, had actually described the sciatic nerve itself reasonably accurately, since nerves, unlike the fine internal geometry of a joint like the knee, are large and visible enough that even limited animal dissection could trace their general path correctly. What Galen and the entire tradition following him lacked wasn't a description of the nerve, it was any understanding of what, specifically at the spine, was capable of irritating it. That gap in understanding is precisely what let the hip disease theory persist for so long, even after the nerve's basic anatomy was reasonably well known. Cotugno performed careful dissections, tracing the actual path of the nerve, and demonstrated convincingly that the pain of sciatica followed the course of a specific nerve running from the spine down the leg, rather than originating from disease within the hip joint itself. His work was significant enough that sciatica was, for a considerable time afterward, referred to in parts of Europe as Cotugno's disease, a small but genuine acknowledgement of how thoroughly he'd corrected a 2,000-year-old assumption. And yet, correcting where the problem originated didn't immediately correct what was actually going wrong at that origin point. Cotugno had shown the pain followed a nerve. He hadn't yet shown what, specifically, was irritating that nerve at the spine. It's worth noting that the hip disease misunderstanding wasn't universal across every medical tradition, even if it dominated the Western record for 2,000 years. Traditional Chinese medicine, developing largely independently, described a pattern of pain running along what practitioners called the gallbladder and bladder meridians, tracing a path down the back of the leg that overlaps remarkably closely with the actual anatomical course of the sciatic nerve, and treated it with acupuncture points positioned along that same pathway, rather than concentrated purely at the hip joint itself. This doesn't reflect an understanding of nerve roots or disc herniation in the modern sense. The underlying theoretical framework remained entirely different, but it's a genuinely interesting example of a separate observational tradition arriving through pure repeated clinical experience at a treatment pattern that traces the nerve's actual path more closely than the dominant Western hip disease theory did for the better part of 2 millennia. That answer wouldn't arrive for another 170 years, and when it did, it came from 2 American neurosurgeons working in Boston, William Jason Mixter and Joseph Barr. But between Cotugno's correction and Mixter and Barr's discovery, the 19th century added its own layer of partial understanding. Worth mentioning because it shaped the vocabulary still used today. Physicians of the era having accepted that sciatica involved a nerve rather than the hip joint itself, began classifying it under a broader category called neuralgia, a general term for nerve pain of unclear origin, applied to sciatica alongside a wide range of other painful nerve conditions with genuinely different underlying causes. In 1864, a French physician named Ernest Charles Lessegue described a simple physical examination maneuver, lifting a patient's straight leg while they lay on their back, and noting at what angle this reproduced the characteristic shooting pain down the leg, a test that, remarkably, given how much else has changed in this story, remains a standard part of physical examination for sciatica today, still known as Lessegue's sign, or the straight leg raise test. It's a genuinely rare example, in this whole account, of an insight from over a century and a half ago, surviving almost entirely intact into modern clinical practice, precisely because it was based on a directly observable, mechanically sound principle. Stretching an irritated nerve root reliably reproduces its characteristic pain, rather than on a broader, more speculative theory of disease that later needed correcting. In 1934, Mixter and Barr published a paper that is now considered one of the genuinely pivotal moments in the entire history of spinal medicine, demonstrating, through careful surgical observation, that a substantial number of sciatica cases were caused by herniated disc material pressing on a nerve root, precisely the mechanism we described a moment ago. Before Mixter and Barr, disc herniation as a cause of sciatica was barely recognized at all. Nerve pain radiating down the leg was far more often attributed to a vague inflammation of the nerve sheath itself, sometimes labeled neuritis, a catch-all diagnosis that, in retrospect, described a symptom rather than explaining a cause. Mixter and Barr's discovery was genuinely transformative. It gave surgeons, for the first time, a specific, correctable structural target, and it launched discectomy, the surgical removal of herniated disc material, as a standard treatment. But like several other corrections we've traced through this channel before, a genuinely important discovery, arriving all at once, tends to overcorrect in the public imagination. And this is exactly what happened here. The phrase, slipped disc, entered everyday language sometime around this period, and it stuck hard, despite being a mechanically inaccurate description of what a herniation actually is. And because Mixter and Barr's discovery had been so dramatic, so clearly demonstrable on the operating table, slipped disc quickly became attached to a kind of inevitability in public understanding. The assumption that any sciatica, any leg pain radiating from the back, meant a disc problem requiring surgical correction. For decades following their discovery, this assumption, combined with a broader mid-20th century medical culture that treated most spinal problems with the same instinct we discussed with the knee, protected through stillness, led to sciatica being managed. Very often, with weeks of strict bed rest, sometimes combined with early, fairly aggressive surgical referral, well before anyone had gathered the kind of long-term evidence needed to know whether either approach actually served most patients well. Surgical treatment itself evolved considerably in the decades following Mixter and Barr's original operations. Their earliest procedures involved a fairly extensive open exposure of the spine, called a laminectomy, removing a substantial amount of bone to access the disc material directly. Over the following decades, techniques progressively refined towards smaller and more precise access. First, a more limited version called a laminotomy, and eventually, by the latter part of the 20th century, microdiscectomy, performed through a considerably smaller incision with the aid of an operating microscope, removing only the specific herniated fragment, causing trouble rather than a broad section of surrounding bone and tissue. More recently still, endoscopic techniques have pushed this trend even further, accessing the disc through a tube barely wider than a pencil. It's a genuinely steady, incremental history of the same procedure becoming progressively less invasive as surgical technology improved. A very different pattern from the single dramatic correction of 1934. But no less important to the overall story of how sciatica has actually been treated over the past century, it's worth mentioning one more piece of vocabulary from this same general era, since it still surfaces occasionally in older relatives' descriptions of back trouble. Lumbago, a catch-all term for lower back pain broadly, in use since at least the 17th century and still common well into the 20th. Lumbago functioned as a description of location rather than cause, lumping together disc-related sciatica, muscular strain, arthritic facet joints, and various other sources of lower back pain under one single, undifferentiated label, useful as a general descriptive term, but genuinely unhelpful for guiding treatment, since it made no distinction at all between conditions with very different underlying mechanisms and very different appropriate responses. Its gradual replacement in medical usage by more specific diagnostic terms, differentiating disc-related radicular pain from other causes of lower back pain, mirrors the same broader trend we've traced across the rest of this channel. Vague, symptom-based labels slowly giving way to more precise, mechanism-based ones. Has the tools available to actually investigate the underlying cause improved? Alongside formal surgical medicine, an entirely separate tradition of manual treatment for back and leg pain developed largely outside mainstream medical institutions during roughly this same period. Osteopathy, founded by an American physician named Andrew Taylor Still in the 1870s, and chiropractic, founded by Daniel David Palmer in the 1890s. Both emphasized manual manipulation of the spine as a primary treatment approach, developed at a time when mainstream medicine had relatively little to offer beyond rest, and surgery remained, as we discussed, an extremely risky undertaking before the arrival of reliable anesthesia and antiseptic technique. Both traditions faced considerable skepticism and at times outright hostility from the established medical profession for much of the following century. Modern research on manual therapy and spinal manipulation for sciatica specifically presents a genuinely mixed picture. Some studies show modest short-term benefit for certain patients, particularly for general low back pain without significant nerve involvement, while evidence specifically for manipulation resolving true nerve root compression remains considerably thinner. It's another instance of a treatment tradition that persisted for well over a century, driven initially as much by the limitations of the medical alternatives available at the time as by rigorously established evidence of exactly how, or how well, it worked. That correction, understanding what the meniscus mistake taught modern medicine, applied here to a different joint entirely, took until the 1980s and 1990s for the equivalent shift to occur specifically around sciatica. Once imaging finally let researchers look past the single dramatic 1934 discovery toward the full, messier picture of how these nerve problems actually behave over time. And then, starting around the 1980s and 1990s, things began to shift, quietly at first, in research labs and spine clinics. A different picture started to emerge, one built not on a single surgical discovery from 1934, but on decades of careful long-term tracking of what actually happened to people's sciatica over months and years, with or without surgery, with or without bed rest. There's a version of the same bone-only blind spot we've discussed elsewhere on this channel, worth mentioning specifically for the spine too. Before myelography, And long before MRI, the only imaging tool available for a painful back was a standard X-ray, which, exactly as with the knee, could see bone clearly but was entirely blind to the disc, the nerve roots, and the surrounding soft tissue. This meant that for decades, when a plain X-ray of someone with sciatica showed bony changes at the facet joints or narrowing of the space between vertebrae, physicians often had little choice but to attribute the pain to whatever bony change happened to be visible, even in cases where the actual culprit was invisible disc material pressing on a nerve root entirely out of the X-ray's reach. It's one more example of a limited window shaping decades of confident-sounding explanation, simply because it was the only window available at the time. Before that shift, though, there was an important intermediate chapter worth mentioning, because it shows how much clinicians wanted a way to see the disc directly. Decades before MRI finally gave them one, in the 1920s, French physicians Jean-Aphémé Sicard and Jacques Forestier developed a technique called myelography, injecting a contrast dye directly into the fluid-filled space surrounding the spinal cord and then taking X-rays, allowing the outline of the spinal canal and any obstructions within it, including a disc pressing into that space, to become visible on the resulting image in a way a standard X-ray, blind to soft tissue, never could. Myelography was, for over half a century, afterward, the primary way surgeons confirmed a disc herniation before operating, and it carried genuine risks and discomforts of its own, including a fairly unpleasant reaction to the dye itself and a recovery period that could involve significant headache. It remained the standard approach right up until MRI became widely available in the 1980s, offering equivalent or better detail without any injection, dye, or radiation exposure at all. One more example of a genuinely clever, hard-won technological workaround, developed decades before the ideal tool existed, gradually rendered obsolete once that ideal tool finally arrived. That shift became possible largely because of the same technology we've discussed in other contexts, magnetic resonance imaging, which by the late 1980s let researchers examine the lumbar spine in exquisite soft tissue detail without any surgery at all. And once researchers had that capability widely available, they did something that, by this point in the story, should sound familiar. They started scanning the spines of people who had no back or leg pain whatsoever, purely out of scientific curiosity about what a normal spine actually looked like. The results, published in a landmark 1994 study in the New England Journal of Medicine, led by researcher Maureen Jensen, were genuinely startling at the time. Scanning the lumbar spines of people with no history of back pain at all, the study found disc bulges in nearly 2/3 of them and outright disc herniations of the same kind Mixter and Barr had identified as a surgical cause of sciatica 60 years earlier, in a meaningful proportion as well. All in, people who had never experienced a day of sciatic pain in their lives. Multiple follow-up studies in the decades since have confirmed and extended this finding. Think about what that means for a second. It means a disc herniation, sitting on its own, on an MRI report, tells you remarkably little about whether that particular spine is actually causing anyone pain at all. This connects directly to that chemical inflammation piece we touched on earlier, and it's worth understanding a little more precisely now. Researchers, including a Swedish team led by Kjell Olmarker through the 1990s, identified a specific inflammatory signaling molecule called tumor necrosis factor alpha, or TNF-alpha, as playing a particularly significant role in sensitizing nerve roots exposed to herniated disc material, work that later contributed directly to the development of medications targeting this same molecule for other inflammatory conditions entirely. Allmarker's research demonstrated something genuinely striking in animal studies. Applying disc material directly onto a nerve root without any actual mechanical compression at all was sufficient on its own to produce significant nerve inflammation and dysfunction, suggesting the chemical exposure itself, independent of physical pressure, could be enough to generate real symptoms. Researchers have found that the actual clinical picture depends enormously on how much inflammatory chemical activity a given herniation is producing at the nerve root, not simply on how large the herniation appears on a scan. A relatively small herniation, if it happens to trigger a strong local inflammatory response, releasing substance P and other inflammatory mediators directly onto a sensitive nerve root, can produce severe, genuinely debilitating pain. A considerably larger herniation, if it isn't triggering the same degree of chemical irritation, can sit there for years, visible clearly on a scan, producing little or no symptom at all. This is a large part of why two people with what looks like an identical MRI finding can have completely different experiences of pain. And it's a direct continuation of everything we've discussed elsewhere about how pain is never a pure, simple readout of structural damage. It's worth connecting this back, too, to central sensitization, the phenomenon we've discussed in other contexts on this channel, where a nervous system exposed to pain over an extended period can become progressively more sensitive, amplifying signals that would once have registered as minor into something registering as significant pain. Sciatica that persists for many months, even after the original inflammatory trigger at the nerve root has substantially settled, sometimes reflects exactly this process. The nervous system's alarm volume having been turned up during the acute phase and not yet turned back down, independent of how much structural irritation remains. Research has found that people with longer-standing sciatica sometimes show broader patterns of heightened pain sensitivity, extending somewhat beyond the exact distribution of the original nerve root, a pattern that overlaps conceptually with what's seen in chronic widespread pain conditions more generally. This isn't a claim that the pain has become somehow less real or less physical. It simply means that the longer a nerve root irritation persists, the more the nervous system itself, rather than the original disc or joint problem alone, becomes part of what needs to settle for the pain to fully resolve. There's a specific clinical observation worth mentioning here, too, developed by a New Zealand physiotherapist named Robin Mackenzie in the 1950s and refined considerably since. The phenomenon of centralization, where certain repeated movements or sustained positions, often though not universally extending the lower back backward, cause pain that had been radiating down into the leg to progressively retreat back toward the spine and eventually diminish entirely before the back pain itself resolves. Mackenzie noticed this pattern initially by accident, observing that a patient who had been lying face down for an unrelated reason reported his leg pain improving, and built an entire assessment and treatment approach around identifying which specific movements produced this centralizing effect for a given individual. Research since has generally supported centralization as a genuinely meaningful, favorable prognostic sign when it occurs. Patients whose pain centralizes with a specific movement pattern tend to have better outcomes overall, though which particular direction of movement produces it varies considerably from person to person, which is part of why this kind of assessment is generally done individually with a trained clinician rather than through a single generic instruction applied to everyone. There's also genuinely encouraging research on what happens to herniated disc material over time, left to the body's own devices. Multiple studies following patients with confirmed disc herniations, using repeated MRI scans over months rather than a single snapshot, have found that a substantial proportion of herniations, in some studies more than 2/3, actually shrink measurably over time, sometimes disappearing almost entirely through a natural process in which the body's immune cells, specifically a type of white blood cell called a macrophage, gradually break down and clear away the herniated material, treating it, in a sense, as foreign tissue to be reabsorbed. Larger, more significant herniations often show the most dramatic resorption, somewhat counterintuitively, likely because they trigger a stronger immune cleanup response precisely because there's more material for the body to recognize and address. This natural history research connects to one of the more influential clinical trials in this entire field, a study led by a Dutch researcher named Wilco Poel, published in the 2000s, along with an earlier, similarly important trial by Swiss researcher Alf Weber, back in 1983, both comparing surgical discectomy against sustained conservative treatment for sciatica caused by confirmed disc herniation. A large American trial known as the Spine Patient Outcomes Research Trial, or SPORT, running through the 2000s, added further detail to this same picture, specifically examining whether earlier surgical intervention produced meaningfully better outcomes than a longer trial of conservative care first. The general finding across this body of research held remarkably consistent. Earlier surgery tended to produce faster relief in the initial months, but by 2 and 4 years out, patients who had a longer initial trial of conservative treatment before eventually receiving surgery, for those who did end up needing it, generally caught up to similar outcomes as those who went to surgery sooner. This gave considerable support to an approach often summarized as a reasonable trial of conservative management first, with surgery available as a genuinely valuable option for those who don't improve adequately within that window, rather than surgery as an automatic first response to a confirmed herniation. Surgery, in other words, appears to speed up a recovery that for a great many patients was already on a trajectory towards substantial improvement on its own. This doesn't mean surgery has no place. For specific situations, including significant or worsening weakness, or pain that genuinely isn't improving after a reasonable trial of conservative care, it clearly remains an important and appropriate option. But it does mean the assumption that a confirmed herniation automatically requires surgical correction doesn't hold up against the longer-term evidence nearly as firmly as the dramatic, single-moment framing of Mixter and Barr's original 1934 discovery might suggest. It's worth acknowledging, too, the genuine complexity sitting underneath spinal stenosis specifically, since it behaves somewhat differently from a fresh disc herniation, and researchers are still working out precisely why some narrowed spinal canals produce severe symptoms, while others, similarly narrowed on imaging, produce very little at all. Some of this likely relates to the same inflammatory and nerve sensitivity factors we've discussed, and some of it may relate to more purely structural elements, like exactly how much reserve space existed in that person's canal before narrowing began. A piece of this puzzle researchers genuinely haven't fully closed yet. There's a genetic dimension worth mentioning here too, similar to what research has found for other joints and structures in the body. Twin studies looking specifically at disc degeneration, the gradual changes in disc height, hydration, and structure that make a disc more prone to herniating in the first place, have found that a substantial proportion of the variation between individuals, in some studies, more than half, appears attributable to inherited factors rather than to occupation, activity level, or injury history alone. This was, when it first emerged clearly through research in the 1990s and 2000s, a genuinely surprising finding for a field that had spent much of the 20th century assuming disc problems were driven primarily by cumulative mechanical wear, heavy lifting, repetitive strain, occupational load. Genetics doesn't override the influence of how a spine is used throughout life, but it does mean, once again, that two people with very similar occupations and activity levels can end up with meaningfully different disc health decades later, for reasons neither of them had any real control over. It's worth adding a broader epidemiological detail here too, since it further complicates the simple mechanical wear story. Disc-related sciatica shows a somewhat distinctive age pattern compared to conditions like knee osteoarthritis. Rather than climbing steadily with age the way many degenerative conditions do, sciatica from acute disc herniation actually peaks in incidence somewhere in the 30s to 50s, becoming, if anything, somewhat less common as a cause of new symptoms in the oldest adults, likely because the disc, having already lost much of its youthful hydration and cushioning capacity by that point, has less material left, with enough pressure and water content behind it to herniate as dramatically in the first place. Spinal stenosis, by contrast, does climb fairly steadily with age, since it depends more on the gradual accumulation of bony and ligamentous changes over decades. It's a useful reminder that even within the single broad symptom of sciatica, the underlying age-related story differs considerably depending on which of the several possible causes we discussed earlier happens to be at work in a given case. It's worth understanding briefly why certain medications work for this specific kind of nerve pain, when others, seemingly reasonable choices, often don't. Standard anti-inflammatory medications, while genuinely useful for many kinds of musculoskeletal pain, often provide only modest relief for the specific nerve root pain of sciatica. Because the dominant mechanism isn't purely inflammatory in the way a sprained ankle is, medications originally developed to treat epilepsy, including gabapentin and pregabalin, are frequently used instead because they work by calming the excessive electrical excitability of irritated nerve fibers directly, quieting the nerve's tendency to fire pain signals more readily than it should, rather than targeting inflammation the way a standard anti-inflammatory does. This distinction is a small practical illustration of something we discussed earlier tonight. Because sciatica involves genuine nerve sensitization, not simply tissue inflammation, treatments aimed specifically at calming an overactive nerve often perform differently than treatments aimed at reducing swelling. Epidural steroid injections, delivering a concentrated anti-inflammatory medication directly into the space surrounding the irritated nerve root, represent another commonly used option specifically for sciatica, guided by the logic that reducing local inflammation at the nerve root directly should reduce the pain it's generating. The research evidence here, gathered across numerous trials over several decades, generally supports a real but often modest and typically temporary reduction in pain, more reliably in the weeks following the injection than sustained over many months, and considerably more consistent for pain relief than for any lasting change in underlying disc structure itself. It's a genuinely useful tool for some patients navigating a particularly severe flare without being a permanent structural fix. Another example of a treatment whose actual evidence profile is more specific and more modest than the confidence with which it's sometimes offered. This connects to a specific and genuinely influential piece of research history worth mentioning by name, since the term itself actually originates from back pain research rather than being borrowed from elsewhere. A British orthopedic surgeon named Gordon Waddell published work through the 1980s and 1990s that was foundational in applying the biopsychosocial model specifically to back and sciatic pain, and it was through this research that the term yellow flags was first coined, describing psychological and social risk factors, distinct from purely structural findings, that reliably predict how someone's back and leg pain is likely to develop over time. Around the same period, a Canadian psychologist named Michael Sullivan developed a formal measurement tool called the Pain Catastrophizing Scale. In 1995, designed to quantify exactly how much a person tends toward magnifying the perceived threat of pain, ruminating on it, and feeling helpless in response to it. Scores on this scale have been shown across a substantial body of subsequent research to meaningfully predict how sciatica and other pain conditions unfold over time. Not because catastrophic thinking causes the initial nerve irritation, but because it appears to genuinely amplify and prolong the resulting pain experience through the same nervous system pathways we've discussed throughout tonight. Factors like significant fear about movement, a strong belief that pain necessarily indicates ongoing damage, low expectation of recovery, and workplace or life stress unrelated to the spine itself, were shown across Waddell's research and the considerable body of work that followed it to meaningfully influence outcomes, sometimes as strongly as the structural findings on a scan. Waddell's work, alongside genuinely groundbreaking work by other researchers of the same era, is a large part of why modern assessment of sciatica routinely includes questions about mood, beliefs about pain, and life circumstances, alongside the physical examination, not as a dismissive afterthought, but as factors with real, demonstrated influence over how the condition unfolds. It's also worth knowing that how sciatica and related disc problems get treated varies considerably depending on where in the world someone seeks care, a detail that, as with the knee, quietly complicates the idea that treatment decisions flow purely from biological necessity. Rates of spine surgery for disc-related sciatica differ substantially between countries with broadly similar populations and broadly similar underlying rates of disc disease, shaped as much by differences in healthcare systems, reimbursement structures, and local medical culture as by anything different happening inside the actual discs and nerves involved. This isn't a claim that surgical decisions are arbitrary. Genuine clinical judgment matters enormously in any individual case. It's simply a reminder that the path from here is what the disc looks like to here is what should be done about it runs through considerably more human and institutional terrain than a purely mechanical model of the spine ever accounted for. Multiple long-term tracking studies have put a more specific, genuinely reassuring number on this natural history. Across a range of studies following patients with acute sciatica from a disc herniation, somewhere around 3/4 to 9 in 10 report substantial improvement within 6 to 12 weeks with conservative management alone, without surgery. This doesn't mean the remaining smaller proportion is somehow failing to heal properly. Some genuinely need more time. Some need additional treatment, and a smaller number need surgical intervention. But it does mean that the overwhelming statistical expectation for a fresh case of disc-related sciatica leans considerably more toward gradual, natural improvement than the fear attached to a fresh diagnosis usually anticipates. As with other joints and structures we've discussed on this channel, the language used in imaging reports has itself become a subject of active reform in recent years. A number of radiology professional bodies have, since the 2010s, worked to standardize and soften the terminology used to describe common, often asymptomatic disc findings, distinguishing more clearly between a disc bulge, a protrusion, and a true herniation with specific, more neutral descriptive language, partly in direct response to research, including a 2015 consensus paper published across multiple radiology and spine societies, showing that alarming or ambiguous language in spine imaging reports was associated with increased patient anxiety and worse reported outcomes, largely independent of the actual severity of the underlying finding. It's a small, ongoing correction, still being implemented unevenly across different clinics and countries, but part of the same broader pattern we've traced tonight. A growing recognition that the words used to describe a finding are not a neutral side detail, but an active ingredient in how that finding is actually experienced. It's worth adding a specific, honest number to this picture too: modern microdiscectomy when it is genuinely indicated. Reports patient satisfaction rates generally in the range of 80 to 90% in most published series, a strong outcome by the standards of most surgical procedures. It's also worth knowing, in the same honest spirit, that recurrent herniation at the same disc level occurs in a meaningful minority of patients afterward, generally cited somewhere in the range of 5 to 10%, depending on the study, which is simply a reflection of the fact that removing the herniated fragment addresses the immediate problem without necessarily reversing the underlying, often partly inherited, tendency of that particular disc to herniate in the first place. There's a specific phenomenon researchers have documented worth mentioning here too, because it complicates the assumption that a nerve problem must have exactly one single point of trouble. The double crush phenomenon, a concept developed initially through research on other peripheral nerves in the 1970s and since applied to sciatica as well. The idea, supported by a reasonable body of subsequent research, is that a nerve experiencing mild irritation or compression at one point along its length becomes measurably more vulnerable to developing symptoms from a second, otherwise, minor point of irritation further along that same nerve, the combined effect of two mild problems producing symptoms considerably more significant than either would alone. For the sciatic nerve specifically, this might mean a person with a mild, otherwise unremarkable degree of nerve root irritation of the spine becomes considerably more symptomatic if a second, minor point of compression also exists further down the leg, at the piriformis muscle we discussed earlier, or at another point along the nerve's path. It's a genuinely useful concept for understanding why symptom severity doesn't always map cleanly onto the size of any single identified structural finding, and why, in some more persistent or unusual cases, a clinician may look for contributing factors at more than one point along the nerve's considerable length, rather than assuming the entire picture must be explained by a single source. So, what does all of this mean for us? Practically? Personally? In our daily lives? Let's start with the myth this whole story keeps circling back to, that a slipped disc is a fixed, permanent structural failure, destined only to worsen, and that surgery is the obvious, necessary response whenever one is found. As we just walked through, the actual research paints a considerably more hopeful picture for a great many people. Herniations that shrink on their own, nerve irritation that calms as inflammation resolves, and long-term outcomes for surgical and non-surgical management that converge far more than the urgency of a fresh diagnosis tends to suggest. This connects to one of the more persistent fears worth addressing directly, that bed rest is the correct protective response to sciatic pain. The evidence runs firmly the other way. Remember that diffusion process we described earlier? The disc's only real source of nourishment, given its lack of direct blood supply. Regular, gentle movement genuinely appears to support that process, while prolonged stillness appears to work against it, which gives the general recommendation towards staying appropriately active a mechanistic basis beyond simply avoiding muscle deconditioning. Walking specifically tends to be well tolerated by a great many people with sciatica, in part because it involves a rhythmic, moderate range of motion through the spine and hip, rather than either extreme stillness or extreme, sudden loading. And several studies have found it associated with genuine symptomatic improvement over time when tolerated reasonably well. A well-known 1995 Finnish study led by researcher Antti Malmivaara compared strict bed rest against simply staying as active as symptoms reasonably allowed for patients with acute low back pain, and found that the group told to remain active recovered faster, and had better function than the group prescribed bed rest. Multiple subsequent studies and clinical guidelines have reinforced this same conclusion specifically for sciatica as well. Prolonged rest tends to allow supporting muscles to weaken, joints to stiffen, and, through mechanisms we've discussed elsewhere in this channel, can allow a sensitized nervous system to become more, rather than less, protective and reactive over time. This doesn't mean pushing through severe, sharp, worsening pain. It means that the instinct many people carry that a hurting back and leg require near total stillness doesn't match what the research on recovery actually shows. It's worth mentioning a specific population who experience a version of this pain for genuinely different reasons. Pregnant women, a substantial proportion of whom experience sciatic-type symptoms, particularly in the later stages of pregnancy. Here, the mechanism is often somewhat different from the disc-driven story we've spent most of tonight on. Hormonal changes loosen the ligaments supporting the pelvis and spine in preparation for childbirth, and the growing weight and shifted center of gravity change how load moves through the lower back, while the position of the baby itself can, in some cases, place direct pressure on the nerve. This version of sciatica generally follows a different, usually more reassuring trajectory, often resolving substantially after delivery as the original hormonal and mechanical factors resolve. Worth knowing, simply because it's a meaningfully different situation from a disc-driven sciatica in a non-pregnant adult, even though the felt sensation down the leg can be remarkably similar. There's a piece of exercise and rehabilitation history worth revisiting here too, because it connects to something we discussed with the knee, the evolving understanding of core stability. Through the 1990s and 2000s, a considerable amount of physiotherapy and fitness culture emphasized strengthening deep abdominal and spinal stabilizing muscles as the central, almost singular solution to back and sciatic pain. Built substantially on research by a Canadian scientist named Stuart McGill and others studying spine biomechanics under laboratory conditions. That research remains genuinely valuable and has meaningfully shaped modern rehabilitation, but subsequent, broader research has tempered the more singular framing that emerged from it. In popular fitness culture, core strengthening appears to be one genuinely useful component among several for many people managing back and sciatic pain, rather than the one decisive fix implied by some of the more enthusiastic marketing that grew up around the original research. It's a smaller scale version of the same pattern threading through this entire night, a genuinely useful piece of research, absorbed by a wider culture and simplified along the way into something more singular and more certain than the original evidence actually supported. There's a specific manual technique worth mentioning too, because its evidence base remains genuinely debated: neuromobilization, sometimes called nerve flossing. A set of specific movements designed to gently glide an irritated nerve root along its surrounding tissue rather than simply stretching the muscles around it. The underlying logic is reasonable. Nerves, like other tissues, may benefit from some degree of movement rather than complete stillness, and restricted nerve mobility within its surrounding tissue has been proposed as a contributing factor in some persistent cases. Research specifically testing this technique against other forms of treatment or exercise has produced a genuinely mixed picture, with some trials showing modest benefit and others showing little difference from standard care, leaving it, like several other treatments discussed tonight, in the category of plausible and reasonably supported for some patients, rather than definitively proven for all. There's a related myth worth dismantling gently: the idea that any tingling, numbness, or pain running down the leg automatically signals a dangerous, worsening nerve injury. In the overwhelming majority of cases, these sensations reflect the kind of irritable, inflamed, but fundamentally recoverable nerve root we've spent tonight describing. Uncomfortable and sometimes genuinely painful, but not evidence of the nerve being permanently damaged. That said, it's worth knowing, calmly and simply, that there is a small set of specific warning signs that genuinely do warrant urgent medical attention, because they can indicate a rare but serious condition called cauda equina syndrome, involving significant compression of the bundle of nerve roots at the very bottom of the spinal cord, a sudden loss of sensation in the area that would touch a saddle, new difficulty controlling bladder or bowel function, or a rapidly worsening weakness in both legs. These symptoms are uncommon, and the overwhelming majority of sciatica, even severe sciatica, never approaches this territory at all. But knowing what genuinely counts as an emergency, rather than assuming every case of leg pain is itself part of replacing fear with accurate understanding. And it's the one piece of tonight's information worth acting on immediately, rather than filing away for later, if it ever applies to you. It's worth revisiting that piriformis question too, gently, since it tends to generate its own particular confusion because the piriformis muscle sits so close to the sciatic nerve in most people's anatomy, and because muscle tightness in that area genuinely can, in some cases, irritate the nerve directly. It's tempting to attribute a very large proportion of sciatic symptoms to this single muscle. The research picture here remains genuinely unsettled. Some clinicians and researchers consider piriformis syndrome, or the broader deep gluteal syndrome category we mentioned earlier, a meaningfully common contributor. Others consider it significantly overdiagnosed relative to spinal causes, in part because there's no single imaging test or clinical exam finding that reliably confirms it on its own. The honest answer, consistent with the uncertainty we've acknowledged throughout tonight, is that the relative contribution of this specific muscle to sciatic symptoms is still being actively debated rather than a settled matter. There's a common piece of advice worth examining with the same careful eye. Aggressive hamstring and lower back stretching, often recommended reflexively for any leg pain of this kind, on the assumption that tightness in these muscles is the primary driver of the symptom. Given everything we've discussed tonight about the nerve root origin of true sciatica, this framing is often, at minimum, incomplete. Stretching a muscle does relatively little to address inflammation or irritation occurring at the nerve root itself. And in some cases, particularly when a true nerve root irritation is present, aggressive stretching into a stretched, tensioned position can actually aggravate the already irritated nerve rather than relieve it, especially in the acute, more inflamed phase. This isn't a blanket statement that stretching is harmful. For some presentations, particularly once the acute phase has settled, gentle, well-tolerated movement, including some stretching, can be a genuinely useful part of a broader approach. It's simply a reminder that reflexively reaching for aggressive stretching as the default first response, without understanding which specific structures are actually involved, can occasionally work against the goal rather than toward it. There's a similarly persistent belief worth examining here, that a single, specific, correct sitting posture, maintained rigidly throughout the day, is essential for protecting the spine and preventing sciatic flare-ups. Research on posture and back pain has, over the past couple of decades, complicated this considerably, while extreme, prolonged, unchanging positions of any kind appear to increase discomfort for many people. Studies comparing specific ideal postures against natural, varied sitting positions have generally struggled to find one single correct posture that reliably prevents pain across different individuals. The more consistently supported finding is that variety and regular movement, shifting position periodically, standing and walking briefly during long periods of sitting, tends to matter more than achieving and rigidly maintaining any single specific alignment. It's a smaller scale illustration of the same lesson threading through so much of tonight. Confident, singular rules about correct body mechanics often turn out to be less universally true than the confidence with which they're taught. Since we're specifically here at the end of a day, it's worth mentioning sleep position too, given this particular channel's fondness for that specific relationship. For sciatica caused by disc-related nerve root irritation, some people find genuine relief lying on their side with a pillow between the knees, or on their back with a pillow under the knees. Positions that can reduce pressure on the lower spine compared to lying flat on the stomach. This isn't a universal prescription. The McKenzie research we discussed earlier reminds us that the position which helps varies from person to person, sometimes considerably. But it's a reasonable, low-risk thing many people experiment with simply by noticing which positions their own body seems to tolerate more comfortably on a given night, rather than assuming one single sleeping posture is correct for everyone experiencing this kind of pain. It's worth addressing body weight here too, briefly, since it tends to arrive with the same undeserved guilt we've discussed with other joints. Additional body weight does increase mechanical load through the lower spine, and some studies do find associations between higher body weight and increased risk of disc-related back and leg pain. But as with the knee, this relationship is considerably less simple and less deterministic than it's sometimes made to sound, tangled up with genetics, muscle strength, activity patterns, and simple individual variation in spinal anatomy. One variable among the many discussed tonight, not a single explanation that justifies self-blame. It's worth returning briefly to a phrase we used at the very start of tonight without examining it closely. Trapped nerve. It's an evocative image, something caught, pinned, unable to move, and it captures a piece of what's genuinely happening in some cases of sciatica, particularly where mechanical compression from a herniation or spinal stenosis plays a significant role. But given everything we've walked through tonight, it's also an incomplete image, one that leans entirely toward the mechanical half of the story, while leaving out the chemical, inflammatory, and nervous system half that so often matters just as much, sometimes more. A nerve root irritated primarily by inflammatory chemicals, with only modest, actual mechanical pressure, isn't really trapped in the way the phrase suggests, even though the resulting pain can feel every bit as severe as a case where genuine compression is the dominant factor. It's a small piece of language, but like slipped disc earlier tonight, it quietly shapes how the whole condition gets imagined as something stuck, requiring release, rather than something inflamed, capable of calming. There's a psychological pattern worth naming here too, one we've touched on in other conversations about persistent pain, the fear avoidance cycle, where pain leads to fear of movement, which leads to avoidance, which leads to deconditioning of the muscles supporting the spine and leg, which in turn tends to worsen both function and the pain itself over time. A loop that, once running, has less and less to do with the original nerve irritation that started it. Breaking that cycle, research consistently suggests, tends to come from a combination of accurate understanding, knowing that movement, appropriately paced, is not causing ongoing damage, and a gradual sensible return to activity rather than either indefinite avoidance or pushing through sharp, escalating pain. It's worth mentioning, too, that a first episode of sciatica understandably raises the question of recurrence, whether, having happened once, it's now simply likely to happen again. Research on this is genuinely mixed and highly individual, but general physical activity and overall fitness levels appear, across several studies, to be associated with somewhat lower rates of recurrence, consistent with everything we've discussed tonight about disc nutrition through movement and the broader adaptive capacity of connective tissue when it's regularly, sensibly loaded. This doesn't guarantee anything for any specific individual. Genetics, as we discussed, plays a real and significant role too. But it does mean recurrence isn't simply a fixed, predetermined outcome waiting to happen regardless of what someone does afterward. There's a commonly used device worth a brief, honest mention here too: transcutaneous electrical nerve stimulation, or TENS, delivering a mild electrical current through pads placed on the skin. Based loosely on the same gate control theory we've discussed in other contexts, the idea that stimulating certain nerve fibers can help dampen the transmission of pain signals traveling through the same general pathway. Research on TENS specifically for sciatica has produced a genuinely modest evidence picture, with many patients reporting some subjective relief during use. While more rigorous trials have often struggled to demonstrate a clear, lasting benefit beyond that immediate sensation. It's a low-risk option that a considerable number of people find genuinely useful as one tool among several, without being a treatment with especially strong evidence behind it on its own. There's a distinction worth carrying forward specifically here, one that's proven useful for a great many people navigating exactly this kind of nerve-related pain: the difference between hurt and harm. Given everything we've discussed tonight about nerve sensitization, about the loose relationship between imaging findings and actual pain, about fear itself amplifying the felt experience of movement, a genuinely irritated, sensitized nerve root can produce real, sometimes sharp pain with certain movements, without those movements causing any further structural damage at all. The two feel identical from the inside, but they are not the same thing, and confusing them is one of the more common understandable sources of fear around a condition like this. 1. This connects, too, to the broader instruction so often given to simply listen to your body, genuinely useful in a general sense, but worth holding alongside everything we've covered tonight about how a sensitized nervous system can produce loud, insistent signals in response to movements that pose no real ongoing risk. It's not a reason to override pain recklessly. It's a reason to hold pain intensity as one meaningful signal among several, rather than as a perfectly precise measure of tissue safety on its own. It's also worth addressing gently the specific fear that so often attaches to any mention of a disc herniation, that it represents an unusual, alarming abnormality in an otherwise perfectly uniform spine. Given the Jensen study and its many successors, showing herniations and bulges in a large proportion of people with no symptoms at all, it's more accurate to think of some degree of disc change as a common, ordinary feature of most adult spines, in much the same way graying hair or fine lines are ordinary features of an aging face, present in a great many people, only occasionally, and for reasons still not entirely mapped out, associated with genuine pain. There's also something worth saying plainly about the genuine uncertainty running through everything we've covered tonight. The honest admission that researchers still don't fully understand every piece of this puzzle, from exactly why some herniations resorb quickly while others linger, to precisely how much any single specific exercise or stretch matters for any given individual. It would be easy to hear that uncertainty as unsettling, evidence that nobody really knows anything for certain. But there's another way to receive it, one that tends to feel considerably calmer once it settles in. Uncertainty about the fine details is not the same as uncertainty about the big picture. We know, with real confidence, that most disc herniations shrink over time. We know pain is shaped by more than tissue alone. We know movement, in appropriate amounts, tends to help rather than harm. The unresolved details sit on top of that solid foundation, not underneath it. It's worth addressing, too, the specific and very common worry about work, whether a physically demanding job or even simply a desk job requiring long periods of sitting, needs to be avoided entirely during a flare of sciatica. The general, evidence-based guidance in most modern clinical settings leans toward modified rather than eliminated activity wherever reasonably possible, adjusting specific tasks, taking more frequent breaks, avoiding a small number of genuinely provocative movements temporarily, rather than complete withdrawal from work. Given everything we've discussed tonight about the downsides of prolonged inactivity for both the disc and the surrounding muscles, this isn't a one-size-fits-all prescription, since the right degree of modification depends enormously on the specific job, the specific symptoms, and the specific individual, which is exactly the kind of judgment call best made with a professional who can assess the particular situation directly, rather than a general rule applied uniformly to everyone hearing this tonight. It's worth mentioning gently that this entire picture, biology, history, psychology, expectation, all interacting together, is precisely why modern, well-supported approaches to persistent sciatica increasingly involve more than a single specialist working in isolation. A physiotherapist attending to movement, loading, and the specific centralizing directions Mackenzie's work identified decades ago, a physician attending to broader health, and, where relevant, medication or injections. And in some cases, a psychologist attending to the fear avoidance patterns and catastrophic thinking that Waddell's and Sullivan's research shows genuinely shape outcomes. Together, these represent a considerably more complete response to the many interacting factors we've spent tonight exploring than any single approach addressing the nerve root alone ever could. There's nothing quite like feeling truly understood by the story of your own body, rather than simply issued a label and sent on your way. That's really what tonight has been. Not a treatment plan, not a set of exercises, but the fuller, more accurate story, sitting underneath a word that's carried the wrong meaning for far too long. So what do we do with all of this in practical terms? The answer, and this might be the least satisfying part of everything we've explored tonight, is that there is no single answer. Sciatica is not a mechanical problem you fix with a wrench. It is a signal, a complex signal shaped by biology, by history, by context, by fear. And like any signal, understanding where it comes from changes how you receive it. For the rest, the different approaches that exist, the strategies that have evidence behind them, the path forward for your particular case. That is a conversation between you and a professional who can look at your body, hear your story, and guide you. What we've done tonight is not give you the solution. It's give you the words, the framework, the understanding you need to ask better questions, and to hear the answers without fear. You're lying there now, in the dark. The nerve we've spent tonight following, the longest one in your entire body, is still there, running its quiet path from your lower spine, through your hip, down the back of your leg, all the way to your foot, doing exactly what it's always done, whether or not it's currently the center of your attention. Think of everything that nerve carries for you, every single day, without asking for a moment of your conscious attention. The signal that tells your foot exactly where it is on a dark staircase. The instruction that lets your calf push you up onto your toes to reach something on a high shelf. The quiet, constant back and forth between your spine and the very furthest point of your body, running in both directions thousands of times an hour for your entire life, largely unnoticed until the single moment it isn't. We started tonight wondering how a problem in your back could be felt all the way down in your foot. Now you know a little more of why. A word borrowed from the Greek for hip, attached for 2,000 years to the wrong part of the body entirely. Centuries of bloodletting and blistering, applied in good faith to a joint that was never actually the problem. An Italian anatomist in 1764 finally tracing the pain back to its actual source. A French physician, a century later, describing a simple test with a straight leg that clinicians still use today. Two American surgeons in 1934, finally identifying what was irritating that source in the first place. A discovery so dramatic, it accidentally taught an entire century the wrong word for what a disc actually does when it's hurt. None of it was carelessness. Each generation did the best it could with what it had, and slowly, correction by correction, the picture became more complete, more accurate, and, this part matters most, considerably kinder to the people carrying that pain. Somewhere, right now, in a spine clinic or a research lab much like the ones we talked about tonight, someone is still refining this picture further, still tracking herniations shrinking on repeated scans, still following patients for years rather than weeks, the way Weber and Puhl once did, to see what actually happens long after the fear of a fresh diagnosis has faded. That work doesn't need your attention tonight. It continues, whether you're thinking about it or not, the same way the nerve running the length of your leg continues its work, whether you're thinking about it or not. Your spine is not a stack of blocks with a disc that quietly slipped out of place. It's a living, adaptive structure, and the nerve running through and beyond it is doing considerably more sophisticated work than a simple wire carrying a single fixed signal. Sensitive to inflammation, capable of calming as that inflammation resolves, and, for a great many people, already on a slow, steady path back toward quiet. Somewhere behind that nerve right now, tiny immune cells are doing exactly the quiet work we described earlier, moving slowly through the herniated material, breaking it down piece by piece, the same patient process that has already, for a great many people who once felt exactly what you're feeling, resolved entirely without them ever needing to think about it again. It doesn't need your attention to keep happening. It happens in the background, the way so much of what keeps a body running happens in the background, unnoticed, unhurried, entirely indifferent to whether you're awake to witness it or already asleep. Whatever it's been telling you lately, however sharp, however far down your leg it's traveled, it very likely knows more and is capable of more than the fear around it usually allows for. A scan is a single photograph, not a sentence about the months ahead. Herniations shrink, nerves calm, bodies, again and again, in study after study, turn out to be better at quietly repairing themselves than the alarming language attached to a fresh diagnosis usually suggests. There's nothing that needs deciding tonight, nothing that needs solving in this exact moment. Just a nerve, the longest one you have, still running its quiet course from your spine to your foot, still doing its patient work, still capable of settling, the same way it has for every other person who has ever felt exactly what you're feeling now, and gone on, eventually, to feel it less, and then, eventually, not at all. The body is not a machine breaking down on a fixed schedule. It's a living, resilient system, quietly negotiating every single moment between what it's asked to do and what it's able to repair. And as you lie there, your body continues its work, quiet, patient, unseen, as it always has.